Very good morning, everybody. It's my great pleasure to introduce today's resident lecture. Today, Petras Laurinavicius will speak. He's from Lithuania. He studied in Vilnius, has worked in many places in Germany and also in Alto, Switzerland. And since a couple of years, he's one of our residents doing an amazing job. So it's my pleasure to introduce you and your talk about Pseudomyxoma peritonei this morning. Enjoy.
So good morning, everyone, and thank you, Professor Lehmann, for the introduction. As mentioned before, today's topic is the Pseudomyxoma peritonei, and I would like to begin with my table of contents. So firstly, I will be talking about this disease or a syndrome itself, including its definition and epidemiology, followed by pathogenesis, classification, clinical presentation, and diagnostic workup. In the second part of today's lecture, we will be talking about the treatment method of choice, the cytoreductive surgery with hyperthermic intraperitoneal chemotherapy, with its general indications, technical features, complications, and results in treatment of the pseudomyxoma. So the term Pseudomyxoma peritonei stands for a clinical syndrome of spreading of gelatinous deposits into the peritoneal cavity. These deposits emerge from a primary tumor, which is in most cases localized in the appendix. However, there can be other primaries, other localizations, for example, ovaries, colon, stomach, and the pancreas. As we all know, there are many different tumors of the appendix, and they all have different survival rates. However, only the spreading of few of them causes the pseudomyxoma, or PMP in short. And these tumors are marked in green in this slide. It's important to know that the peritoneal seeding of all other appendiceal lesions should be regarded as peritoneal metastasis and not as PMP. The appendiceal mucinous neoplasms are the most frequent cause of the PMP, so I will be mostly focusing on them during this presentation. They are a pretty rare finding, causing up to 2,000 cases yearly in the United States. They have, however, rising incidence over the last decades, slight female predominance, and they are usually an incidental finding. Talking about the epidemiology of PMP itself, one of the newest efforts to evaluate it was undertaken in 2020 by the colleagues from Norway and the UK. They have analyzed the national registries of these two countries between 2009 and 2018 and came up with an average incidence of 3.2 cases per 1 million people per year. Now I will briefly overlook the pathogenesis of the PMP. So the pathological process starts in the appendix with a neoplastic transformation of appendiceal goblet cells and the formation of a primary mucinous tumor. Secondly, the overproduction of mucin and the obstruction of the appendiceal lumen causes the development and subsequent rupture of a mucocell. In this photograph, we can see a specimen of a distal portion of appendix which has been ruptured because of a pressure from the mucus collected inside of the mucocell. Thirdly, these tumor cells enter the peritoneal cavity and start circulating with the peritoneal fluid, and they are being redistributed and accumulate in the specific parts of the abdomen, for example, in the right subdiaphragmatic space, greater omentum, or pelvis. Moving forward to the classification, it's important that we classify both the primary tumor and the PMP itself. I would like to begin with the classification of appendiceal mucinous neoplasms, which was done by the WHO. And firstly, we have to differentiate the type of tissue invasion. So it could be either pushing or infiltrating the surrounding tissue. The pushing tumors are then further classified into having low or high-grade cytological atypia, as in LAMN or HAMN. The infiltrative tumors are classified in accordance of signet ring cells, whether they have it or not. The classification of PMP was not unified and controversial for a long time, till in 2015, the Peritoneal Surface Oncology Group International developed it with together 71 international experts from the whole world. This classification distinguishes 4 types of PMP. So firstly, we can have mucin without any epithelial cells, and it has the best survival rates. Secondly, we can have mucinous carcinoma peritonei with either low or high-grade cytological atypia. And the last type is the high-grade mucinous carcinoma peritonei with signet ring cells, which has the lowest survival rates. So now I would like to ask my fellow residents, what do you think? What is the clinical presentation of the PMP?
I would say it's like symptoms similar to an appendicitis as well as a distended abdomen.
Yes, that is correct. So 30 to 50% of the patients present themselves with an advanced disease, and the symptom of it is the jelly belly, which is increase in abdominal size and abdominal discomfort because of a massive mucus accumulation inside of the abdominal cavity. However, the patients who do not have the advanced disease present themselves with localized symptoms according to the localization of mucus accumulation. So, for example, if the mucus is collecting in the right lower quadrant, the patients could have appendicitis-like symptoms. And it's important to note that in up to 20% of the cases, it could be a coincidental finding during imaging studies or surgery. So to unify the diagnostic workup, a global advisory, which was also initiated by the PSOGI group, was created, and the consensus statement was made by 80 PMP experts worldwide. To summarize the diagnostic guidelines, I would like to begin with the imaging studies, and the CT scan was defined as a gold standard for the diagnostic and follow-up because of its high sensitivity in detecting the tumor hurts, as we can see in the table above. Moreover, absence of tumor hurts bigger than 5 centimeters in the epigastric region on small bowel was associated with a higher probability of a complete cytoreduction. Here I would like to show you a CT scan from a patient from our clinic who had a massive mucus infiltration surrounding his liver, spleen, as well as in his small bowel and in the pelvic region. The serum tumor markers also were defined as a diagnostic tool for PMP. And the most commonly used tumor markers are the CEA and CA99. They have been associated with increased postoperative survival if they are measured in normal range before the surgery. This was demonstrated by the Dr. Sugarbaker in his study where he analyzed 532 patients with PMP who underwent the CRS-HIPEC procedure and were followed up after that for 5 years. What he could show was that the patients who had normal CEA and CA99 levels 1 week before the surgery had statistically significantly better survival rates after that. Moreover, these two tumor markers are directly related to the tumor load. The preoperative colonoscopy was also defined as a diagnostic tool for a PMP, and the importance of it lies in the probability of asynchronous tumors. This was demonstrated by the colleagues from New Zealand, where they analyzed almost 8,000 patients after appendectomies over 16 years, and 74 of them had appendiceal tumors. It's important to look at the statistics, and we can see that 14 of them had synchronous colorectal cancer, which has to be ruled out or proven before we begin with a definitive treatment. The diagnostic laparoscopy also plays a very important role in the diagnostic workup because the limiting factor of a complete cytoreduction are the lesions undetectable by the cross-sectional imaging. And the laparoscopy enables minimal access means to predict the tumor resectability. When it is performed, there are several rules that we have to follow. So firstly, it's important that the trocars are placed in the midline because if the patient happens to have tumor hurts on his abdominal wall, we can spread them to the skin when we are removing the trocars. And those possible skin metastases can, after that, be removed during the laparotomy. Secondly, the diaphragmatic biopsies should be generally avoided because of the risk of diaphragmatic perforation and seeding of the tumor cells into the pleural cavity. And lastly, the PCI score has to be calculated. And I would like to ask you, what do you think, what is the purpose of the PCI score?
Well, the PCI score is to determine the extent of the peritoneal spread of the tumor. And depending on that, we can judge if the tumor, well, first of all, the prognosis, and then if the tumor is resectable.
Yes, that is correct. So the PCI score was established in the 1990s by the Dr. Sugarbaker as a tool to objectively quantify the spreading of peritoneal masses in general. The abdomen is divided into 9 segments and the small bowel is divided into 4. Each segment gets a score between 0 to 3 according to the lesion size in that segment, so that the maximum score of 39 can be achieved. In the context of PMP, it was shown by Dr. Terrence in his multicenter retrospective study, where he analyzed more than 2,000 patients with PMP, that the postoperative survival rates after the CRS HIPEC are directly related to the preoperative PCI score. So, moving forward to the treatment. It is the CRS HIPEC. As you may have noticed, it consists of 2 parts. So, firstly, we have to remove all of the macroscopically visible tumor with the help of cytoreductive surgery. However, as the Dr. Paul Sugarbaker, who is the pioneer of the CRS HIPEC procedure, once said, "It's what you don't see that kills your patient." Therefore, it is crucially important to eradicate as many as possible microscopic tumor cells with the help of hyperthermic intraperitoneal chemotherapy. With this graph, I would like to show you the indications for the CRS HIPEC, and as we can see, it is the gold standard only for the pseudomyxoma. Some other types of tumors, for example, ovarian cancer, could be managed in this way in highly selected cases, and there are some tumors that are never being managed this way. To begin with the cytoreductive surgery, I would like to show you some examples from our clinic, before and after pictures, beginning with the upper abdomen. As we can see here, the omentum majus was severely infiltrated with the mucus, and after the CRS, it has been completely removed, as well as the parietal peritoneum. This is the same for the small bowel. And here we can see a specimen of a colon, rectum, parietal peritoneum, and spleen and omentum, everything removed en bloc, and it shows how extent the cytoreductive surgery can be. To objectify the completeness of cytoreduction, the CC score was introduced, and it could be defined between 0 to 3, with 0 being no residual tumor visible after the surgery, and 3 being the tumor hurts bigger than 2.5 centimeters in diameter after the CRS. Talking about the complications, the CRS HIPEC was heavily criticized for a long time because of its high morbidity and mortality rates. However, as the systematic review of Dr. Chua, which included 24 non-randomized trials, showed, the most common complications were ileus, abscess, and fistula. Moreover, the study from Professor Lehmann from 2016 showed that most of the complications after the CRS HIPEC procedure are up to grade 3A, as we can see in the table below. It means that the majority of the complications can be managed without reoperation. The colleagues from Germany wanted to evaluate the risk factors and to look up when we can expect the postoperative morbidity. So they included more than 2,000 patients after CRS HIPEC for various indications. And what they found out was that if the pancreatic resection, anterior resection of the rectum, or at least one anastomosis is being done, the postoperative morbidity increases. Moreover, if the center was doing more than 100 cases a year, it was considered to be a negative risk factor for fistula, pulmonary embolism, and postoperative mortality. So, moving to the HIPEC part, it is the lavage of the abdominal cavity with a chemotherapeutical agent with a minimal temperature of 42 degrees Celsius. Here we can see some pictures from the OP theater. The first one being the pumping device, which is controlled by a skilled cardio technician in our clinic. The second and third photos show all the needed safety measures because we are working with the cytotoxic substances. Those being special gloves, special mask, special cover for an operating field, and the hose for the vapor. So for the finalization of our lecture, I would like to present you the results of treatment of the PMP with this method. I would like to begin with the study made by Dr. Sugarbaker, where he compared the CRS-HIPEC procedure with the serial tumor debulking. And after follow-up of 20 years, the patients had 70% survival rate after the CRS-HIPEC, which is high contrast to the serial tumor debulking. However, there are several factors that play important role so that we can get the best outcome for our patient. Firstly, the colleagues from France wanted to evaluate the postoperative outcomes with the peritoneal extent. They included 245 patients. 61 of them had extent disease with a PCI greater than 28, and the rest of them had a non-extent disease. These patients had PMP, of course, and they underwent the CRS-HIPEC procedure and were followed up for 5 years. What they found out was that the overall survival and the disease-free survival was better in non-extent disease, and the results were statistically significant and are associated with the difficulties of achieving the CC score of 0 when the disease is advanced. Secondly, the study of Dr. Terrence showed that the resection status also plays an important role in the overall survival, and even R1 resection has significantly better survival rates than the major tumor debulking. And lastly, it has been seen that some patients with a low-grade PMP have different survival and reoccurrence rates. The colleagues looked at the tumor biology and found that the appendiceal mucinous neoplasms show one of the highest rates of KRAS mutations amongst the human cancers. And Dr. Pietro Antonio made a study about it and showed that the patients who had KRAS mutations had a significantly lower survival rates after the CRS-HIPEC procedure. So to summarize today's presentation, the pseudomyxoma is a clinical syndrome and not a disease per se. The treatment of choice for it is the cytoreductive surgery with HIPEC, which is a big procedure. It has, however, not so many complications that require the surgery. And survival rates are influenced by the tumor type, tumor biology, PCI score, and resection status. Thank you for your attention.
Thank you, Petras, for your beautiful and very clear presentation. I learned a lot. Nice images. I think you nicely showed us that a little stupid organ, tiny organ, can cause huge problems. And what we thought over the last centuries that this is just a stupid jelly belly. I mean, the term tells you what we thought about has changed dramatically. We learned that it is a very heterogeneous disease which needs dedicated treatment and sometimes very invasive and advanced surgery. I think one of the challenges for the future will be to subclassify this disease and to get this surgery maybe less invasive and on the long term create less disabilities in our patients. Thank you very much. Petras, do you have questions?
Petras, congratulations. Very clear presentation of a difficult topic, perfectly done. And you also gave good credit to Professor Sugarbaker in Washington, who was a pioneer. He was very criticized, considered as doing things that make absolutely no value. He was very persistent and come now with data up to 20 years. And I thank also Professor Lehmann, who is in charge of this surgery here and has developed that very well. I think it needs someone dedicated for that. And I would like also to give a tribute to Professor Gertsch, who was working with Sugarbaker, who was here for some time and introduced this therapy with us. And even a few years ago, we have to face a lot of criticism from our hospital, not for this indication. I think you've shown here, I don't think there's much discussion for this indication, but many others. And there is currently still a debate. Data is missing. So maybe my question to Professor Lehmann, you showed a different disease for which this therapy could be used. Could we just, in couple of minutes, tell us now what do we do here and what's the level of evidence of using the HIPEC strategy for this other cancer. Your presentation was so clear that there's probably not many questions on this.
Well, we choose to talk, or Petras choose to talk about pseudomyxoma because it's important to have a closer look at this disease. But you're right, this cytoreductive surgery is performed for many indications. And there has been a lot of discussion, studies and debates on that topic. But briefly, I think pseudomyxoma is probably the best indication because there's little chemo or systemic treatment available. And for all other diseases where systemic treatment has made also some advances, the role of surgery is constantly challenged. On the other hand, better chemo enables more surgery because it selects patients that have stable disease. And it's probably not a game against each other, but rather together. For colorectal surgery, there has been a randomized study which shows a clear role for cytoreductive surgery, the PRODIGE 7 study, but it's not so clear whether HIPEC adds something on top. So surgery, yes, HIPEC, we don't know. For ovarian cancer, we have 2 studies available, 2 randomized trials that show a benefit for cytoreductive surgery and HIPEC. Still in that field, it's not very frequently done, particularly in the German-speaking countries. For gastric cancer, there are studies that show some benefits in very highly selected patients. And the critical issue here is they're quite rare. It's basically their tumor biology that defines whether they are good candidates. That was probably a very brief answer.
Thank you very much for this talk. Are you using always the same intraoperative chemo during the HIPEC?
We're currently evaluating that, also in our basic research lab, because we do not know which type of chemo we really should use and what effect we actually want to get with our perfusion. So right now, most perfusion protocols use mitomycin or oxaliplatin, but that's a topic which is pretty under investigation.
Thank you very much. Very nice talk. I have a question to the PCI for PMP. Is there a cutoff for doing CRS?
Well, for pseudomyxoma, no. Usually in pseudomyxoma patients, you try to get it out unless you cannot take it out because it infiltrates the liver hilus, for example, or the small bowel, the complete small bowel. For all other diseases, there are recommended PCI limits which depend on the tumor biology.
Okay, thank you very much.
Thanks.